Hi, good afternoon. This is Dr. William O'Neill. I'm the Executive Dean of Clinical Affairs at the Miller School of Medicine, University of Miami. I think at the peak, some hospitals were approaching over 90% use of drug-eluting stents. Again, there's been a significant, about a 15% decline in the percentage, but not only in the percentage of drug-eluting stents, but also in the total number of stent procedures. There's been a substantial decline per 100,000 people. I'm told there's about 1 million PCI procedures in the U.S., so, again, probably 850,000 procedures with drug-eluting stents and about 150,000 without at its peak. Yeah, just very briefly, there's this term called complete revascularization that comes from coronary bypass, and there's literature that suggests that the more vessels are bypassed and the more complete the revascularization is with bypass, the longer the survival for patients. So interventional cardiologists trying to transmit that concept towards the interventional realm, and people thought that they should do as complete a job of opening stenosed vessels as they could. The problem is that some of the vessels sort of had intermediate severity lesions, and there wasn't really very much information about whether or not those should be fixed. When we did balloon angioplasty on those vessels, there was a risk that they could restenose or that they could dissect and you need emergency bypass. So the cardiologists actually were pretty conservative about treating vessels that weren't severely stenosed because there was a lot of risk and not a lot of proof that there was benefit. With the advent of regular stents, that number sort of crept up because it was safer to operate on those intermediate severity lesions. There was a little bit of a risk of restenosis, but not very much danger. And then when the drug-eluting stents came on the fore in 2003 and 2004, there really didn't appear to be any reason why not to fix those vessels. Even if they were just intermediate stenosed, when you put a drug-eluting stent in, you'd open it, there would be very little risk of restenosis. And so there was actually a lot of exuberance, and there was an explosion in the number of drug-eluting stent procedures and vessels that were treated. So then in 2005, 2006, there was some information that started to come out about the fact that drug-eluting stents actually had a potential for harm. This concept of subacute occlusion or acute occlusion. So patients would be doing fine, and all of a sudden, without warning, the stent would close off, and 60% of those patients either died or had a heart attack. So it was a very, very severe problem. Although this only happened infrequently, it sort of had a chilling effect on the community, and people then again became more concerned about only treating vessels that were severely diseased. At the same time that this risk came out, the COURAGE trial came out, which is a randomized trial of best medical therapy compared to best medical therapy with stenting, and it was apparent that best medical therapy worked just as well as aggressive stenting. So you've got, on the one hand, not a lot of evidence showing there's value, and on the other hand, a huge increase in risk. So that really, again, had a very chilling effect. Then the final piece of information came out about 2 years ago, where physicians in Europe used a catheter to create fractional flow reserve. So they would put a tube across a stenosis and see whether or not it was truly hemodynamically significant. And they found about 60% of the time when they looked at these intermediate severity lesions that they really didn't cause hemodynamic problems, and there was no need to stent those. And there was a randomized trial that was done. If there was an intermediate severity lesion, they checked with fractional flow reserve and then randomized. And the people that had fractional flow reserve actually did better. There were fewer heart attacks in that group of patients over about a 2-year follow-up. So all three of those things combined, I think, have really significantly dampened the enthusiasm for a sort of over-exuberant implantation of drug-eluting stents. I think the thing that the community, the lay community and the scientific community have to understand is that on an elective basis, drug-eluting stents are only indicated for relief of symptoms. So if a patient has exertional angina, severe limitation of exercise capacity, can't have their usual quality of life, then at that point, patients should have something to revascularize. And if it can be done with stents as a perfect solution, stents are a very effective form of therapy for relieving angina or relieving exercise-induced ischemia. Out of that context, if you're doing the stenting for any other reason, there isn't a lot of scientific evidence that it works. We know that elective stenting doesn't prevent heart attack, and we know that elective stenting doesn't decrease mortality. So you have to be very cautious about why the procedure is being performed. And unfortunately, many interventionalists were using this, again, for the concept of complete revascularization or for perhaps prolonging life or preventing heart attack. Neither of those indications are valid. So I think that in settings where you're not relieving symptoms or relieving exercise-induced ischemia, then there really is no validity for placing drug-eluting stents. So there has been all of this kind of concern about overuse of drug-eluting stents has really now transmitted into the legal climate and even the criminal climate, which is very alarming to me. There have been cardiologists that have been kicked off of medical staffs, and one cardiologist in Florida actually has legal proceedings and perhaps even having his license revoked because of allegations of overuse of stents. In these cases, and I've reviewed a number of these cases, the cardiologists are placing stents in lesions of intermediate severity. So the vessel is stenosed anywhere between 20 and 70%. Just looking at the angiogram, it's very difficult to tell whether or not those lesions are actually causing problems. And again, I think that throughout the interventional community, there are probably 10 or 15% of cases where there was sort of soft indications for using these stents. And I think that what this is going to do is really going to have the cardiologists be very, very careful about patient selection and lesion selection, because now there is a risk that if you are treating a patient incorrectly, that either malpractice suits or even criminal procedures could be brought against you.